Good morning. I'm Rick Botney, and this is Medication Labeling 101. How do I do this? Forward. Good. So I occupy space on a number of different committees, but I have no financial disclosures. The top three committees are most relevant to what I'm doing here today. And so I'd like to set the stage by briefly reviewing some history related to medication errors and medication labeling, and then look at why we label medications, consider how standards differ from guidelines and statements. And then after that, I can discuss in more detail the ASA statement on labeling, the role of the United States Pharmacopoeia, and the standards that are published by ASTM. So John Snow discussed the death of Hannah Greener while she was under chloroform anesthesia. And this was likely the first report of a medication error in anesthesiology. He attributed her death to an overdose of chloroform that had been administered in an uncontrolled fashion. 20 years later, there was a medication-related death that was brought before the courts in England. And during the inquest, the doctor explained that the appearances of bismuth, the intended medication, and strychnine are similar. And wherein the judge outlined two possibilities. One, that the poison had been administered by mistake, or two, that there had been gross negligence because the doctor's drugs and poisons might have been kept in such a way that he could not tell which he was using. I think this is a medication swap and probably occurred because the medications were not labeled. The first contemporary mention of medication errors was in 1953 in the nursing literature. Medication errors at that time were considered to be a nursing problem. And despite steps taken to reduce their likelihood, the errors continued to occur. The following year, Beecher and Todd reported on the death rate attributable to anesthesia and whether deaths were due to the agents themselves or to the techniques used, or whether errors such as the choice of agent or how it was administered played a role. One important finding they had was that muscle relaxants were associated with a high death rate. However, when they looked, the incidence of any clearly recognized gross misuse of these agents was so low that they stated it could hardly be called an important factor. In contrast, 30 years later, in their critical incident analysis of errors in anesthesia, Jeff Cooper and his colleagues found that drug administration errors and syringe swaps were the most common critical incidents in anesthesia in the operating room. In the 1990s, there were several things taking place. The Harvard Adverse Drug Event Study was conducted, and at the study's conclusion, a summary of the study was written of the previous 10 years experience, but a leading anesthesiology journal declined to publish it. And it suggested that medication safety in anesthesia was not a topic of significant interest at that time. However, soon thereafter, medication errors began to be recognized as a significant issue. Discussion of them was being included in ASA programs, and publications on the subject were becoming more frequent. At the same time, the Australian Incident Monitoring Study examined 2,000 incident reports, and Curry and colleagues reported on 144 incidents that involved a wrong drug administration, and they found that 63% of syringe errors occurred despite correct syringe labeling. And this is where I want to thank Joyce War for her comments about cognitive errors, because for various reasons, including no doubt those cognitive errors, correct labels were being read incorrectly. The authors concluded that labeling is only one of a range of strategies necessary to prevent syringe swap errors. And the 1990s also included ASTM's publication of the first international labeling standard. We'll see more on that shortly. In 2001, Webster and Mary quantified the drug administration error rate as 1 per 133 anesthetics. And they also reported that most substitution errors involve drugs from a different class, suggesting that the use of color-coded labels would have considerable potential for reducing interclass errors. In 2004, the first statement on the labeling of pharmaceuticals for use in anesthesiology was published by the ASA. And more recently, Karen Nagy and her colleagues found that medication errors and adverse drug events occurred in 5% of all medication administrations in anesthesia, and that labeling was the most common type of error. So, why do we label medications? It serves several purposes. Its general role is to reduce the occurrence of medication errors. Although we know errors can still occur even when labeling is correct, it does not change the fact that labels, in my opinion, are a necessary and important part of the error reduction process. Labels enable the accurate identification of medications to make sure that the correct drug is being given. In addition, having the concentration displayed on the label can make or may make dosing errors less likely. Labels may also have additional information such as the patient's name and the route of administration, and that the medication is not beyond its expiration date. Standards, guidelines, and statements serve different purposes. Standards provide the expectation that a measurement or the production of an item will not vary and can therefore be trusted. That is, that things are done in a uniform way so that outcomes do not change and are reliable. In addition, standards are typically viewed as requirements and that they are enforceable. So now we'll get into the heart of the talk. The original ASA statement was approved and published in 2004. The gist of the statement was that the main consideration in label design was to reduce medication errors and promote safer patient care. The statement also showed support for the use of medication labels that were consistent with the ASTM D4774 standard. The most recent statement was approved and published in 2020. It had been significantly revised, mostly by myself, and has a fair bit of additional content. But the basic message of this statement is unchanged: to promote safe patient care through a reduction of medication errors. Also, by this time, the ISO had published an international standard for label design, so the ASA statement now supports the use of labels consistent with both ASTM and ISO standards, plus recommendations from the FDA and ISMP. The original United States Pharmacopoeia, shown here, the cover of which is shown here, was published a little over 200 years ago. There are a number of statements in the preface of the original publication, which are also shown here, that describe USP's role. The two underlined statements relate most to the topic of labeling. First, labeling helps to prevent uncertainty regarding the medication named on the label by ensuring that drugs have a definite name. Second, ensuring that medication names are not similar helps to avoid mistakes in medication identification and selection. In order to achieve these objectives, USP has created a robust naming process that is the responsibility of its nomenclature and labeling expert committee. USP standards are found in the US Pharmacopoeia as well as the National Formulary. These official compendia are recognized in the Food, Drug, and Cosmetic Act, and while compliance with the standards are mandatory, USP has no role in enforcing these standards. That falls to the FDA and other government authorities. The most relevant chapter for labeling is General Chapter 7. It specifies the label content, for injectable products and describes a format for most of the items that we find on labels. It applies to official articles, which are medications for which they have written a monograph and to which an official name has been given. The primary expression of strength is almost always given as the total amount of drug per total volume, despite what many of us who are anesthesiologists believe is not the best way to do it. Exceptions do exist for circumstances where the primary expression of strength has not been effective in preventing errors. One example is insulin, and another example is the use of ratio expressions for single entity medications such as epinephrine. Because ratio expressions have been the source of frequent errors, they are no longer permitted for these single entity medications. Instead, the strength is now given as the amount of drug per volume, for example, 1 milligram per ml. Some other requirements in General Chapter 7 include labeling for potassium and neuromuscular blockers in recognition of their potential for deadly errors, for how expiration dates are expressed for compounded preparations, the use of leading and terminal zeros, for electrolyte concentrations, and that certain abbreviations shall not be used. ASTM develops and publishes voluntary consensus standards with the help of over 30,000 technical experts and professionals like myself. Under certain circumstances, the standards can become mandatory. The 4 standards shown here are the ones that are important to our work. D4774 provides specifications for user-applied syringe labels and is possibly the most relevant. Additional standards specify the identification and configuration of pre-filled syringes, labeling for small volume parenteral drug containers, and methods to enhance the identification of drug names on labels. All of these were withdrawn by ASTM in 2022. And that means that they are no longer available for reference by organizations such as pharmaceutical manufacturers or label producers. To remedy this, APSF became a member of ASTM, and I was asked to represent APSF in order to get these standards reinstated and, where necessary, revised. The first one I worked on is D4774, which was first published in 1994. At that time, the only international labeling standard. It specifies color coding and other aspects of label design, including label size, content, and font characteristics, and how drug concentrations are represented. It also served as the basis for several national standards at that time, including in Australia, Canada, and the UK. When I reviewed 4774, I observed that it had a number of errors of various types, and its content needed to be aligned with contemporary practice. So I made the necessary revisions and submitted it for reinstatement. Hopefully, that will be accomplished in the next few months. Since ISO also publishes an international standard on user-applied syringe labels, why is reinstatement of D4774 necessary? Well, there are a number of differences between the 2 standards, which are shown in this table, or these tables, and I believe that 4774 is still relevant and necessary. For example, it is used in the United States market, while ISO is intended more for the international market. One way in which this is reflected is in the differing terminology used for certain drug names. For example, succinylcholine here and succinylmethonium in many other parts of the world. In addition, D4774 identifies 9 different drug classes and provides color coding for each of them, while ISO only identifies 8 classes. Local anesthetic concentrations, this is my slide, can be indicated as either percentages or in milligrams per mil, but ISO has no such specification. And the revised version describes tall man lettering in much more detail than ISO does. If I had to boil down my message, it would be these three items. Labels are important for reducing medication errors and improving safety. That label design matters in that endeavor, and that standards provide important guidance for label design. Thank you.